Hello, everyone. Good morning. Welcome to Night International Academic Sports Science Congress in Azerbaijan. First of all, dear Robert, we will can start. Add you, Robert. Robert is here. Yes. Good morning, Robert.
Yeah, hi.
Hi, how are you?
I'm fine, thank you. And you?
Thank you so much. Welcome to
Okay,
Night International Academic Sports Science.
thank you very much. Nice to meet you. And
Nice to meet
I
you.
I would like to try the my presentation, okay?
Okay.
Uh, uh, okay, let's try. Yeah. And
Yes, I saw.
yeah,
Yes,
okay.
yes. If you are ready, dear Roberts, you can
Yeah,
start. Okay,
okay.
okay. Thank you.
Moment, please. Uh,
Your total times about 10 minutes, 15 minutes.
okay,
Okay, Roberts. Thank you so much.
okay. Moment. I screen. Okno. Okay. First of all, I would like to thank the organizer for inviting me this conference. My name is Robert Trybulski. I'm professor of physiotherapy and MMA coach. I represent the Upper Salesian Academy in Katowice from Poland. And today I would like to present our research cycle about the evaluation on contrast therapy in post-exercise recovery of the musculoskeletal system. And before I continue my presentation, I would like to mention about two most popular myths which I often hear from my athletes. First myth is the coach. I'm a young athlete. I don't need anything more than only good sleep and proper nutrition. So I think that it's only partially true because of course the good nutrition and the good sleep are the fundamental base of the recovery strategy, but without the clever strategy recovery, but especially the without the recovery methods difference, especially the load management, uh, this recovery process is absolutely can be leads to overtraining. The second myth, which I often hear from my athletes, is the more sweat and tear in the training, the less blood in octagon. True, it's difficult because we have a recovery process. Even the best training leads to overtraining. What is the key to success? I think that is load management, training, rest, and recovery. I'm supporter for the multimodal approach for the strategy recovery, and one innovate, one promising, interesting methods of represent the multimodal approach of recovery strategy is the game ready system. What is the game ready system? Because, okay, I think that there is no single perfect recovery method, and the game ready is interesting method, and is we can use the combining compression and thermal stimuli, rapid temperature control from 3 and 45 Celsius degree, and within the seconds, and adjustable compression level 45 15 for 75 millimeters mercury. We can use the real-time automatic adjustment of pressure and temperature, the same within the seconds, and can be used the cold therapy, heat therapy, and contrast therapy. This is the multimodal approach for this interesting therapy. And what are the benefits in this therapy? First of all, increased tissue perfusion by the vascular pumping effects of the alternating cold and heat. And secondly, we can reduce swelling and improve the natural lymphatic drainage, especially by the intermittent pneumatic compression, and decrease muscle stiffness, improve the elasticity as muscle function, and especially the stiffness and the high pain pressure, and we can support the post-exercise recovery, especially the power and strength recovery. And during our research, we employed hemodynamics and biomechanical model for assessing microcirculation system. Why? Because the microcirculation system is important, is crucial for the cell nutrition, thermoregulation, and the power recovery. Actually, we can observe that during the load management and the regular exercise, the capillary density and the new angiogenesis process is absolutely important symptoms, maybe the phenomena, but the reaction system microcirculation is also important. And that's why we used during our research cycle the post-occlusion hyporeaction test. And this test is not only important for the assessing the microcirculation reaction in sports recovery, but also we can use this test for the assessing the initial symptoms of cardiovascular disease. Yeah, and up to now, and the scientific literature, we can meet the too long protocols for the using the game radiant contrast therapy system. For there was the difficult to apply in recovery practice. That's why our main aim of our study was to evaluate the shorter and more practical protocols. And during our study, we collaborate different scientists from 8 Polish university and 8 in other countries. Up to now, we published the 9 paper, 6 are under review now, and total impact factor this paper is about the 30. In our study groups was the site range from 20 and 45, especially the elites MMA fighters, sometimes the combat sport athletes, amateur soccer players, and young volunteers. And during our study, we use the methods of recovery assessment, objective and subjective. And objective method is especially the laser Doppler flowmetry and ultrasound control for assessing the microcirculation and reperfusion reaction, Newton Pro for the muscle tone, stiffness and elasticity, Kivnen force and the maximum for isometric and voluntary strength, a force platform from the example, the jump test, algesimet for the pressure, pain threshold, and blood biochemistry difference, and especially for the DOMS assessing the kinase creatine and the interleukin. We know this. I would like to pay attention for the one interesting objective method of microcirculation assessment, and in this the laser Doppler flowmetry, because the laser Doppler flowmetry is a not invasive method. Can we use the laser light to assess the microcirculation by the measuring the movement of erythrocytes on the surface of 1 millimeter square of tissue in real time? What is the limitation this method, especially the measure only skin microcirculation, not muscle directly, but we can meet in the scientific literature that the true skin response often reflects muscle response. And the second lead is the very sensitive method, especially the results depend sometimes on the proper measurement condition. And we used the different measurement point, especially the baseline rest, immediately post exercise, and follow-up assessment was the 24, 48, and 72 hours. And study design, we organized the crossover study, multi-arm study, and self-control study. What is the general conclusion in this research cycle? First of all, the shorter post-exercise recovery protocols, especially 10 and 2 minutes, absolutely are effective as longer ones, for example, 30 and 40 minutes. And we have the major practical implication: recovery process can be efficient and time-saving. And cold compression, heat compression, and contrast therapy is interesting hypotheses, are all effective. We cannot observe that, for example, the main hypothesis that contrast therapy will be the significant result, and cold compression shows rapid effects even after 6 minutes. After our study, we postulate for the using the cold compression therapy and 10 minutes. And heat compression therapy, we observed that needs to more time. We postulate the 20 minutes. And the high compression pressure is important results after this study, especially 75 and 100 millimeters mercury is essential for effectiveness. Lower pressure is absolutely or less efficient and should be avoided. For example, 20 millimeters mercury and 20 and 40, and the first pressure is we can observe the effects is about 60 millimeters mercury. And how the limitation, how are the limitation this study? First of all, the sample size, because our study we included especially the elites MMA fighters, and we had the 20 and 45 participants in our research. Especially we focus on mainly the MMA elite fighters and combat sports athletes, because I'm an MMA coach. And for the easier the organized for me this study, and focus on the short-term outcomes, only the 72 minutes, not the we don't assessing this adaptate process, only the recovery immediate effects. And what are the future direction, especially the longer multi-center randomized clinical trial across especially diverse sports, long-term study, especially on the repeated recovery cycles, maybe some the more blood biomarkers, especially the hormone, and are associated with the muscle fatigue. And especially we should personalize the protocols by the sports, sex, and training loads. Here are our reference this different study. And finally, I would like to mention the one interesting paper, the post-exercise physical recovery methods for combat sports, a scoping review. After the scoping review, we have the same practical takeaways than I mentioned today, especially that I think there is absolutely no single perfect methods. Effectiveness, different recovery methods depends on timing and absolutely individual response. And what's promising strategies after this scoping review is first of all, active recovery and normal rest, cold water immersion, and I postulate the high compression cold stimuli, and dry needling therapy is interesting methods. And so the final conclusion is the method selection equals the matching training goals and athletes preference. Thank you for your attention.
Thank you so much, dear Roberts. Thank you for your presentation. If our viewers have any questions, we can take them. Just a minute. I saw we haven't questions, and dear Roberts.
Okay.
Thank you for your again presentation, and thank you for your participation. Our Congress.
Yeah, thank you very much. My colleagues, my PhD students, my colleagues, professor, waiting for your presentation.
Yeah, thank you so much. Thank you so much. Thank you so much for everything, Roberts. See you soon. Next year.
I hope.
Okay. Thank you. See you.
Ciao. Thank you very much.
Ciao. Next word in Jaroslav Murachki. Hello, dear Jaroslav.
Hello.
How are you?
Doctor? Yes, I'm fine. Thank you. I would like to thank my dear friend, Professor Robert Trybulski, for inviting me. And I am very happy to be here with you and that I can show you my presentation. My topic.
Thank you.
So,
we are waiting.
Should we start now?
Yes, share.
Okay, so I would just try to share the screen.
Yes. I don't see right now.
Give me a second. I'm just doing this.
Yes.
And please let me know if you can see the presentation.
Yeah.
Yeah.
Okay,
so we can start.
Yeah. If you are ready, you can start.
Yes, I am ready. So I'm glad to be here, and I would like to interest you with my topic, which is pain monitoring in many aspects like sport, clinical practice, and daily living. 2 words about me. I work in Poland in the Szczecin University. I had some scientific practice in many universities. One of them is the Bandırma University from Turkey, so quite near to the organizers of this presentation. Daily, I work in football, and I have experience in many clubs and also Polish national representation and the Polish amputee football representation. And I had also coaching practice in many clubs around the world. So this is my background. So give me a second. Okay, so the plan of this short presentation is, as you can see, we have 4 elements here. First of all, I will tell you shortly about what is actually pain and why it is important. Then one slide about traditional ways of pain measurement. And then I will be glad to show you the new tool for pain monitoring, which is digital pain drawing. And at the end of my presentation, I will show you some practical examples of digital pain monitoring. When it comes to the definitions of pain, you have like hundreds of them. Why? Because many specialists use the definitions specific to their knowledge and to their needs. So you have definitions used by medical doctors, physicians, sport practitioners, like coaches and sport medicine specialists. You have different definitions of pain for the standard populations and many, many others. In this chaos, here comes the International Association for the Study of Pain definition, which says that pain is an unpleasant sensory and emotional experience associated with or described as actual or potential tissue damage experienced by a person. So, as you can see, this definition is very subjective, and for a MMA fighter, something would be never pain, but for the same stimulation for the standard population, just a random guy, will be a high intensity pain. So, is the subjectivity a problem or an advantage? From the researcher's point of view, this should be an advantage, in my opinion. Why? Because this is one of the most important characteristics of pain, meaning that it is an individual experience influenced by psychological, cultural factors, and many others. So, when a person just claims that he or she feel pain, we have to take this because the definitions say so. So pain will always be subjective phenomenon. And here comes the question, why is pain important? Because it's present. It's present in every person's life. For some people, it's a past and they are very thankful, but not fully safe. For some people, this is a current problem. So they feel pain and they just pray for a relief. And for some people, this is future. So now they are healthy, they feel no pain, but in future, for 100%, they are endangered by pain, which comes from many like life aspects. It can be caused by trauma, by illness, even by daily routine or your work. And in this presentation, I would like to think about the pain which comes from sport, many sport disciplines. And I cannot imagine a sport discipline which is completely free of pain. There are many traditional ways of pain measurement, starting from the easiest and the most, the oldest, the most traditional. We have verbal reporting and description here, which is natural. Then we have paper and pen methods and different scales like visual analog scale for pain monitoring and similar. And then we have palpation and manual pressure methods, functional investigation methods, and here we start to use some equipment, some electronic or mechanical equipment for pain measurements, and I mean algometers. We have also more advanced methods like EEG and other neuroscientific methods and many others. And what is the, let's say, share point, the main point of all these methods? All of them are very time consuming. So imagine if you have a team of 20 players and you give a 10 minutes talk with every of the player, you have 200 minutes, which equals over 3 hours. So this is a lot of time. And in sport, there is always deficit of time. No matter at which level or how much money you have, the team sports always face time deficit. So we have to have and use time efficient methods. And that's why this new tool was investigated. It was made in Denmark by a company Eglance Solutions, which CEO is Professor Shelly Ann Boudreau Christensen, and she developed with her colleagues this application, which name is Navigate Pain application. It is very simple and serves to pain monitoring in all of the life aspects. What are the advantages? The application is very easy to use. It's validated scientifically method. The application collects visual data and also digital data. It is, of course, it is still subjective by a patient, but it brings objective data for a clinician. It enables monitoring, comparing, and following the process of treatment, of regeneration, of what you want here. It enables searching for patterns, like pain patterns, assessing therapeutic effects like minimal detectable change and minimal worthwhile change. It enables calculating the injury risk. And what is most important, it is very time saving because the players or your patients can do it by themselves. After educating them, they can do it like remote on their mobile phone or a tablet or a laptop computer, and you have all the data from all the patients in just a minute. And now I would like to show you some practical use of this application, and in scientific research projects we already published. The first one is the amputee football pain study. This is the first attempt in science to measure and monitor the pain experienced by the amputee players. The study was made on the Polish representation. We were investigating them for over 2 years when they were preparing to the European Championship, which was held in Poland. We monitored the anthropometric measures, the subjective scales like rate of perceived exertion, and we also educated the players how to use the Navigate Pain application. We were monitoring the training camps, all of the trainings, and also the official matches during the international tournament. Here you can see the pictures of maps experienced by one of the players. We called this representative player. This guy was very important to the team. He played in all of the matches and scored a lot of goals. And as an example, you can see in which zones he felt a pain after training, after international tournament matches. Beside the visual data, by which you can just follow the process visually, this is very important for the physiotherapists. You also have the numbers, which tells you about the area of pain and the intensity of pain, and also you have the quality data about the the quality of pain, the kind of pain that the player experience. And here you have a graph showing the results. The first is the recall pain. So this is the player's recall of how they usually feel about after the amputee football match. The next two labeled as first training camp and second training camp. These are the actual measured area of pain after trainings on the training camp. And the four following labeled as one international tournament, second international tournament, and again. These are the actual area of pain experienced by all of the players after the matches, the official matches during an international tournament. So by having this, you can compare and you can see the trend that from match to match, the area of pain in these players grows. And on some margin, I can tell you that this tournament was very easy for our players. We were dominating and winning all of the matches. So imagine what will happen if you have more matches and if you have stronger opponents. The second and the last one, because I have few time, but I also want to show you this. Our second study using Navigate Pain is the goalkeeper's performance versus pain study. In this study, we had a big group of 24 goalkeepers. We were doing digital pain mapping and training. It was a training camp, and we were measuring their speed in a speed test with reaction after all of the training sessions. We applied a standard goalkeepers training containing all of the goalkeeper actions like offensive actions, defensive actions, and here on the right you can see the speed test. It was a short distance with reaction, which just mimics the goalkeeper action during the real match situation. So he also have to observe, he have to start, he have to choose direction of movement. And here you have some graphs, and I will give you a summary of these. On the left, you have the RPE and PPR, which tells you that the goalkeepers are in a very good state. So they are not physically exhausted. The fatigue is low. They have a big willingness to take part in the next session. So they want to train. They don't feel physical fatigue. But the low left corner, you can see how many of the goalkeepers feel pain. And for the 5 days, it is on average 20 keepers out of 24 who felt pain during this tournament. On the right side, you have the graph showing you the pain area. These are the blue markers showing you the pain area and its evolution, and the black line just show you the speed test result. And here, looking at the speed test result, the differences are minimal, and they are not statistically significant. And now the best, just look at the keepers. Now here you have the pain maps of the keepers, and here this is selected only the muscle pain, so we can call it delayed onset muscle soreness effect. And one of my colleagues just said that this is a pain of the whole person, so almost whole body main muscle groups are covered with pain. And what this actually tells you, that even if you talk with your players or your fighters, even if you measure them with a speed test or reaction test, you can think that they are in very good shape. But actually, what they feel inside, this is a lot of pain, and it really multiplies the injury risk. And imagine if you have one goalkeeper and you have a lot of injury risk, you are, as a coach, you are a very risky person. So this pain monitoring gives you additional information which can be very important for the team management and adjusting the player's load. We have much more publications which use the Navigate Pain application. So if you are interested, if I managed to grab your attention, just look on my ResearchGate, you can find the publications there. So it was a really short run. I hope that you could follow, and I would like to thank everybody for the attention. Thank you.
Thank you, dear Yaroslav. Thank you for your presentation. Just a moment. If our viewers have questions, we can take them.
Yes,
just
of
a
course.
moment, dear Yaroslav.
I will try to answer if I could.
Yeah. Okay. Thank you, dear. Dear Yaroslav, we haven't questions. Thank you for your participation, and see you next year at our Congress.
Yeah.
Nice to meet you.
All the best to you and the organizers. Thank you very much.
Thank you so much. Take care, dear Yaroslav. Next work, again, Roberts.
Yeah.
Hello again, Roberts.
I have some
Welcome.
question, and for you, Jarek. Yes, in your opinion, what the main challenges in the implementing this digital monitoring system?
Yeah, okay.
The question is for Jarek, and I don't know who you are, Jarek. Oh,
dear Yaroslav, is it here?
sorry.
Yaroslav.
Okay. So
maybe next to Roberts.
Okay, sorry.
Guys, can you hear me now?
Yeah.
Yes. Okay. So I just turned off the microphone, so you couldn't hear me, but I've heard the question. The main challenge for me is very simple. This is the player's education.
Here you are, Roberts. Here you are.
Yes.
Yeah.
So you have to spend some time to educate the players and help them to interpret and just evaluate the pain they feel. So they have to think about this and to just distinguish between muscle pain, the impact pain, the joint pain, and also fatigue. Because some people really think that if they are actually fatigued, they are exhausted. They say they feel pain, but this is not true. So in our study, we spent like a month for just educating the players, and we were using this application with them, so all the time with them for a month for some training camps. And after this period, we just started to collect data, because the initial data was not true.
Yeah.
Sometimes the players just said, "Oh, I feel no pain." But if you talk with him and ask precise questions, it occurred that he felt pain, he felt swelling, he felt some neural pain, and a lot of pain. But initially they said no pain.
Okay.
So this is the main issue. But after that, if you work with the professionals, they really can use it, because we also made a study on American football of the team which plays in championship league. This is the highest league in Europe. So it was just easy for the professionals. They understood this.
Mhm.
So, Robert, thank you for
Yeah.
this question.
Thank you very much.
Thank you very much, Yaroslav. See you.
See you.
Yes, Roberts.
Yeah, thank you. That's all. Thank you very much.
Thank you so much. Your
I
presentation.
sent you the information about the schedule, people. Yeah.
Yes, I saw. Your
Thank you.
next work, yours.
Yeah. What is the problem?
Yes, I don't see your presentation, Roberts.
My colleagues know me. Now the Kamil Gałęziok should be have the presentation. Oh,
This one?
no, is this okay? This Gracjan Olanishin. Yeah. Oh, it's okay.
Okay, hello everyone. Can you hear me?
Yes, of course.
Yes.
Yes.
Okay,
Welcome.
thank you for invitation me. Good morning, everyone. My name is Gracjan Olanishin, and I represent the Department of Medicine, the Wojciech Korfanty, Upper Silesia. I'm not sure you see my presentation. You see my presentation?
Yes, of course.
Yes. Okay. Thank you.
Yes.
Okay.
If you are ready.
Yeah, I'm ready. Okay.
Okay.
Hello,
You can
everyone.
start.
Okay, good morning. My name is Gracjan Olanishin, and I represent the Department of Medicine, the Wojciech Korfanty Upper Silesian Academy in Katowice, in Poland. And I also run a private physiotherapy practice, Olanishin Center for Physiotherapy in Racibórz, Poland. This is my pleasure to present the results of the study conducted by my therapeutic team concerning adverse reactions to dry needling therapy in clinical practice of Polish physiotherapists. This is the first study of its kind in Poland to systematically examine how often and what types of side effects occur after dry needling, and whether they are linked to the therapeutic level of experience. For those of you unfamiliar with the technique, dry needling is a physiotherapy method used to treat myofascial pain. It involves inserting thin, sterile needles into triggered points, tight, painful spots in muscles. Unlike acupuncture, dry needling is strictly based on anatomy, neurophysiology, and biomechanics. It is often used for low back pain, neck and shoulder pain, tension headaches, and overuse and restricted range of motions. For my own clinical experience, dry needling provides very fast pain relief, but like any invasive technique, it carries some risk. We wanted to find out how often side effects really occur, not just serious one, but also minor on that can affect pain comfort, and whether more experienced therapeutists actually see fewer complications, something we often assume but really verify. The aim was to describe mild and serious adverse effects of dry needling therapy and to investigate whether those reactions were depending on the therapist's level experience. We conducted an online survey. 102 Polish physiotherapists currently using dry needling participated. They were divided into 3 experience groups: 0 to 2 years, 3 to 6 years, and over 7 years. The questionnaire had 27 items asking about side effects observed over the past week, the past month, and through the responder entire career. It converted mild effects such as bleeding, pain, bruising, tingling, and rawness, and some serious complications like pneumothorax, infections, hospitalization, or nerve damage. In the past week, 7% reported bleeding, 68% reported pain during the procedure, 52% reported post-procedure pain. In the past month, 49% reported bleeding, 44% reported bruising. Serious complications, 14% reported nerve injury at least once in the career, 3% reported pneumothorax or shock, 2% reported infection, and 1% reported hospitalization. Experience level had no significant impact on the most adverse events, except for tingling and rawness, which were more often reported by the therapeutists more experienced. Dry needling is relatively safe. Most adverse effects are short-lived, low in intensity, and are not related to the therapist's level of experience. Still, serious complications are too rare, but can happen. So, proper training, anatomical knowledge, and patient screening remain essential. Study limitations. Data were retrospective, based on the therapist's memory. We didn't record the exact number of procedures, so we can't calculate incidence per 10,000 treatments. Patient characteristics like age, comorbidities were not considered. We recommend perspective studies where side effects are recorded immediately, and better tracking procedure counts to calculate precise complication rate. This study confirms that dry needling therapy is safe and effective method, but it also highlights the need to talk openly about its limitation. By doing so, we can improve both clinical practice and patient education. Thank you very much for your attention. I will be happy to answer any question. if there are some questions.
Thank you for your presentation, Gracian. Just a moment. If our viewers have any questions, we can take them.
I hope not Dr. Trybulski. He always have hard questions.
Professor.
Professor, yeah.
We have not.
No, I
We
have
have questions.
No, thank you.
Thank you for your presentation,
Thank you very
Gracian,
much.
and then thank you for your participation. See you next year at our Congress again.
Thank you. Yeah, thank you very much.
Nice to meet you. Thank you so much. Have a nice day. Take care.
Thank you. Bye.
Dear Roberts, next work, who is?
Maybe Kamil Gałęziok and Filip Matuszczyk.
Philip. Yes, Philip. Hello, Philip.
Can you hear me?
No, I didn't see screen. Just sounds. Okay, Philip, dear Philip, next work, and then Kamil.
Yeah. Oh, perfect. Yeah, Philip
Hello,
just
Kamil.
has some problem with connection. So good morning, everyone.
Yes.
I'm not sure. Do you see my screen?
Okay. I saw. Yes, dear Kamil. If you are ready, you can start.
Okay, so just give me a second. And right now, you see my screen, yeah? Everything is okay?
Yes. Thank you.
Okay, perfect. So good morning, everyone. And first of all, I would like to thank the organizer for the opportunity to present this topic to you. My name is Kamil Gałęziok. I am a physiotherapist and PhD student. And I would like to present a study that my team and I published on the problem we faced when diagnosing and treating the soleus muscle injuries. And this topic is often overlooked, but crucial, especially for athletes. So today I will walk you through the anatomy and function of the soleus muscle injury and highlight why diagnosis injuries to this muscle can be particularly challenging, and discuss both traditional and advanced treatment strategies. So let's get started, and it's crucial to acknowledge the complexity of the calf due to the numerous structures present in its area, such as the gastrocnemius muscle, soleus muscle, Achilles tendon, plantaris muscle, and other factors and structures that should be considered during the diagnosis of injuries. And additionally, the soleus muscle itself adds to the complexity, primarily due to the internal structures such as lateral and medial aponeurosis and the central tendon, which can each sustain injuries, and moreover, significant individual variability in these structures. So, for example, including difference in length, adds to the diagnosis challenges, making accurate assessment during the initial patient's evaluation more difficult. So let's focus on the anatomy, and the soleus makes up to 70% of the total surface area of the posterior leg. Its primary function include plantar flexion of the foot and maintaining stabilization, but it's also one of the most important muscle during the running due to its endurance properties, as it is rich in type 1 slow twitch fibers. The soleus has lateral and medial aponeurosis and a central tendon, as seen in the cadaveric image at the right side of the presentation. The pronar origin, which is the superior to the tibialis, originates from a thick band of tendon in the posterior sector of the fibular head. And the tibial bundle originates from a bony prominence on the posterior aspect and from the medial border of the tibia bone. So we have 3 areas in one muscle where we can expect injury, which makes diagnosis extremely difficult. And imaging and clinical studies often miss subtle injuries due to its dislocation and overlap with gastrocnemius muscle, as well as the complex anatomy as described earlier. So the tendons within the soleus are commonly used to determine the site of injury in soleus strain, and soleus strains often involve the muscle tendinous junction or myofascial junction. And in addition, symptoms can mimic other conditions such as, for example, Achilles tendinopathy or tennis calf. And tennis calf is an injury of the medial head of the gastrocnemius muscle. But symptoms of soleus are often not as severe as symptoms of tennis calf. So the type and intensity of pain may be more similar, for example, to Achilles tendinopathy. Patients often report experiencing a dull pain in the calf during the match, but they are typically able to complete the game and walk without the crutches, without the help of crutches. And the gold standard for diagnosis, the soleus muscle, due to the complexity of the muscle and the depth of its location, is MRI. Ultrasonography is a useful tool, but it has limitations, such as being highly dependent on the experience of the examiner. And the soleus muscle is located deep, which in the case of ultrasound compromises the quality of imaging. And this slide shows that we have a very important table differentiating the symptom of the soleus and gastrocnemius muscle. As you can see, during a soleus injury, the pain is most felt in the posterolateral part of the calf. And during a gastrocnemius injury, patients often report immediate intense pain in the calf, more at the medial side, local swelling and tenderness around the medial gastrocnemius muscle, and tennis leg is associated with difficulty in weight bearing, unlike the diagnosis of the soleus muscle. So we can very well access the gastrocnemius muscle on ultrasound, and MRI is usually not necessary for future treatment. And the treatment of soleus injuries is almost always without any need of an operation, and surgical treatment is only included when long-term rehabilitation does not bring the intended results. So the conservative treatment protocol in the first period is carried out according to the PRICE protocol. But by this we mean protection, rest, pain, and swelling relief with ACE and compression and limb elevation. In the second stage of rehabilitation, we include stretching, strength, and range of motion exercise to rebuild muscle function. And in the first and second stage of rehabilitation, it's worth considering to use, for example, blood flow restriction training, which I will talk about later in the presentation. The first stage of muscle adaptation involves increasing the intensity and volume of muscle loading to increase their load capacity. The functional training stage includes the procedure from the previous stage, with the addition of sport-specific exercise to prepare for return to activity. And of course, the education and prevention that accompany the entire rehabilitation, so that the patient is aware of how to prevent this type of injury in the future. And the duration of each phase depends on the location and extent of the injury. So advanced therapeutic approach. And in some cases where we have the opportunity to use advanced tissue healing methods, we may consider. So first of all, blood flow restriction training, which allow us to increase the intensity of exercise in the first stage of rehabilitation by increasing metabolic stress when we cannot fully load the tissue and want to subject it to appropriate stimulation. Also, we can use another therapy like a plateau-rich plasma injection, which aims to enhance body natural healing response by delivering growth factors directly to the site injury. We can also use laser biostimulation or TECAR therapy. And when structural damage is significant, sometimes minimally invasive surgical intervention may be necessary, although they are relatively rare for soleus injuries. And the choice of advanced therapy must be individualized based on the extent of the injury, the athlete's goal, and their return to activity schedule. So the key takeaways. So soleus muscle injuries are very often underdiagnosed. Early diagnosis is essential to prevent the patients from developing chronic muscle strain. Well-defined and diagnostic protocols are necessary to minimize the risk of misdiagnosis, and proper understanding and treatment of soleus injuries can significantly improve patients' outcomes and help athletes safely return to sport. So thank you very much for your attention, and I welcome any question that you may have.
Thank you for your presentation, dear Kamil. Is here just a moment. If our viewers have any questions, we can take them. And then we haven't questions.
Okay.
Thank you for your presentation, and then thank you for your participation, dear Kamil.
Thank you very much.
You're welcome. Roberts?
Yeah, okay. And I have a question.
Thank you, dear
Thank you very
Kamil.
much.
See you next year at our Congress.
See you. Thank you very much.
Thank you so much. Have a nice day. Nice to meet you. Yes, Roberts. Next.
Yeah, maybe let's try the connect with Philip. If
Philip?
you're not Philip, maybe another colleagues.
Philip is here.
Yes, can you hear me?
Yes, and not see.
Okay. I just upload my presentation, but I can't see it on the main screen.
Oh, yes, okay.
Yes, okay.
Okay, so if you can hear me, I thank you for invitation, especially for Professor Robert Trybulski and whole crew staff that we do researches together. Okay, so I represent Provita Medical Center Żory from Poland and my own business that's called Matuszczyk Physiotherapy in Katowice. Okay, so that thing that I wanted to share with you is our study that we did last year. It's called Effect of 10-week plyometric training on anaerobic performance and biomechanical properties of the muscles in football players, randomized controlled trial. Okay, so what is plyometric? At first, we have to know what it exactly is. So plyometric training is a widely used method that utilizes a biomechanical mechanism called the stretch shortening cycle. In the way we can develop the ability of the neuromuscular system to generate the maximum force in the shortest time possible. Plyometric exercises are characterized by high speed, short duration, and maximum effort, requiring the activation of motor units that are associated with fast twitch type 2 muscle fibers. Okay, what did we study? A group of 20 players from a 4th football league team were subjected to a study aimed at checking how plyometric training performed twice a week for 10 weeks would affect biomechanical changes in muscles, as well as sprint and reactive strength. Experimental group was 10 people and control group was also 10 people, 10 players. So we measured sprint for 5 and 30 meters. We measured RSI, reactive strength index, is a ratio between the time of impact of the ground when you're landing and want to jump off, and the high of the jump. So biomechanical properties for rectus femoris and vastus lateralis was also measured by myotonometry. Okay, so the experimental group training was three main exercises that they prepared was hardless jump, multi-jumps, and drop jump. They did the same training for 10 weeks, 2 times per week, and they tried to do it before the main training session of football. The control group was doing normal training session with any other footballers. What did we get? As you can see on the figure, for 5 meters sprint, the control group also improved their times, but experimental group highly developed their speed. Their times was better after the whole research. For 50 meters, as you can see on a picture, also improved for the experimental group. RSI also was better for the group that was in experimental group. And only properties of the muscle that changed was for rectus femoris muscle elasticity. That was the only thing that changed significantly, but any others changes wasn't observed. So, as I told you, no more significant changes in biomechanical properties were observed. We assume that it will take a longer time for significant differences to be observed. Maybe we need more time to see bigger changes in our muscles. Conclusions. Do plyometric, always max intensity, full rest. If you want to improve your power, if you want to improve your ability to develop your speed in any other sports, always do on max intensity your plyometrics. 2 times a week with minimum 2 days rest between sessions. It's very important that we don't want to do too many plyometric sessions. 2 times is enough. Jump forward, sideways, and do drop jumps. So approximately 50 jumps per session in total at the beginning is enough. If you want to increase your training volume, do it by about 5% per week. Do not jump more than 100 jumps per session. Okay, and remember about progressing your training sessions, about progressing your plyometrics. So, in our opinion, future researchers should focus on optimizing plyometric training, volume intensity relationship, and time and money outlay to maximizing the final effect, and look for various other training solutions that increase the motor potential of athletes. Don't forget that plyometric is just one of the effective tools to be faster, more jumpy, generate more power. It will not replace classic strength of power training. Yesterday I wanted to add some to the slides, but I want to tell you that you have to remember the most important thing in any sports is doing good your sport. You have to be good in playing football, you have to be good in playing basketball, you have to be good in playing volleyball. Plyometric sessions or nutrition things or recovery parts, it's also important, but it's only the icing of the cake. So remember that there is no good player that can't play football well, but he's only, for example, jumping. Thank you for your attention. If you have any questions to me, please go on. I'm ready.
Thank you for your presentation, Philippe. Hello again, Robert.
Hello.
Just a moment. If our viewers have any questions, we can take them. Just a moment. And then we haven't questions right now. Thank you for your presentation and thank you for your participation, dear Philippe.
Thank you very much.
Thank you so much. See you next year at our Congress.
Yeah, I will come. I will
I
come.
hope.
Thank you.
Thank you. Dear Robert, do you have any questions?
No, thank you very much.
Okay. Okay, thank you so much, Philip. Have a nice day. Nice to meet you.
Thank you. You too. See you.
Thank you. See you. Next one, Roberts.
Next one, probably my colleague Professor Sebastian Klich. Next, the Dr. Michał Nowak.
Okay.
Now probably the Sebastian Klich. Oh yes. Hello, Sebastian.
Hello.
Hello, dear Sebastian.
Hello. Thank you for having me.
Thank you so much. Welcome to Knights International Academic Sports Research Science Congress. If you are ready.
Yes, I need actually a minute just to upload the presentation.
Okay.
Yeah, could you just let me know?
Yes. Dear Sebastian. Good morning, Michelle. Next work, Michelle. Hello, Michelle.
Hello, hello. Are you hear me?
Yes, of course. If you are ready, you can
Yes,
start.
I'm ready.
Yeah.
Of course, if it my time, of course I'm ready.
Okay, okay, okay. Your presentation.
Hello. For the start, maybe a little introduce myself. My name is Michael. I represent today on the Congress that my university, Jan Długosz University in the Częstochowa. I'm working on the Collegium Medicum. That I have two the parts of my life. The second is I represent the science department on the soccer, one of the best soccer academy in the Poland. It's the RKS Raków Częstochowa. Today I prepared that the short message from our work that our study comes from many years of monitoring of Raków Academy's players. We want to bring the scientific standards into the daily coaching. It shows how to data can really help young players grow. Yes, the title is Normative and Limit Values of the Speed, Endurance, and the Power Test. Okay. The introduction of the presentation, because in my opinion it's important. On the picture the up you see the normal typical percentiles grids that use of the many last years in the different kind of companies. Yes, this only the height on the BMI index. In my opinion, in the young footballs, winning is not the primary goal. The most important thing is players' progress, and that's come from the hard work. Until now, we haven't had a tool to measure players' improvement clearly. Yes, our study offers a new solution to this problem. Yes, our goal is to develop a tool from the better monitoring and very important that decision making, because decision making it's very helpful with the daily work, not far to the players. Yes. The little characteristic of our group, because it is important. the group was very stable with almost no players changes of the 5 years. It's allowed to us to observe the really grow and not random variation. Yes, the study involved the 495 players. 2018 to 2022. It's the period of the 5 years. They were ages 12 to 16, and we divided them into the 5 ages groups. On the pictures, you see the typical picture from the dressing room after the winning the game. In my opinion, working with the young players is very interesting and give me the chance to watch the progress. In my opinion, it's very helpful. The methods, the short message about the methods. Our idea to prepare the methods, it's easy to transfer from all the words, and because our science department is created to create the transfer and build the bridge between that science and that normal typical training session. And we use that speed test, power and endurance. Speed is very easy because it's only the time on the distance 5, 10 and the 30 meters. Of course, we have electronic fit lights to measure. It's perfect. The power is very easy because it's only that long jump from the standing position. That's a very easy test. And endurance, it's famous very popular on the soccer words from the Martin Boucher. It's important is the definition how the formula maximal aerobic speed is created, because it's estimate of the 80% on the final result. I told about the mass because on the result, on the picture, on the graphs, we use the mass because the transfer of mass is easy from the coaches. Yes. We have the results of the speed test. The biggest speed improvement was between ages 13 to 14, when both the nervous system and the muscle power developed together. On the numbers, you see the biggest gain were 0.126 seconds on the 5 meters, 0.215 seconds on the 10 meters, and 0.717 seconds on the 30 meters. Yes, it's very important. We looking for the new players scouting process. Yes, new players to the join to invite the new players to our team. We're looking the best players. That percentile show us if you start with the biggest result, it's very difficult to working with this kind of players, because if you have the best result on that, it's very difficult to the next test prepare the better result in the future. In my opinion, it's very important that all the 89% our cases, our analyze show that the players have improved results of the speed test. Yes, there is the final version of the grid from the speed test. In my opinion, show where a player stands compared to the peers. It's a simple diagnostic tools from the both potential and the limitation. Its limitation is very important. The next result is the power. Power, you remember, it's easy test because it's only the long jump. The 48 centimeters gain and the percentile 25 show us how the power and coordination development together. It's also remind us the progress. Sometimes it's not linear. It's very important. The next slides, of course, the final version of the power test. This is the difference between the percentages are very, in my opinion, natural. They reflect manipulative thinking and explosive strength level. The next result about the endurance, and endurance is very interesting because increases the most between the ages 13 to 14 and the 15 to 16. This is when the body learn how to handle high intensity work effectively. But if you see what's happened on that percentile 3 or 10 between that ages 13 to 50, you see it's very stability, and we don't see the progress. In proof, what's that? Of course, that 24%. It's some like that. Our work is not the best, in my opinion. But if you see that the numbers, the great improvement was at 0.6 meters by seconds. Yes. The next slide is the grip. Of course, if you want use, I give you a chance. This chart helps support players who progress faster than average, and it suggests when the training load can be safely increases. It's very important to coach push. For example, that prepare the special exercise in the training session to push harder the players' work. The finished conclusion, I prepared the 4 important points, but I think it exists the 5. The first is easy because we have a new tables. Will help check your current result and future progress more accurately. Yes. The second, the new tables that give the chance the individualization of training. You see the personal training. They help the plan. They help the management training better, and based on the player's age and level. Very important is the database should be updated every year. It's very important because if we done it, to make the model more accurate every time. And the final conclusion, in my opinion, is very, very important because the charts are not the judgment but a tool. They help understand where a player is today and where he can go tomorrow. It's very important. In my opinion, this is the most important message from my presentation. It's only the tool. Then if we can use that have an option to understand the details. Final slide, of course, the finished. Thank you for the attention. The full paper is available online. You see that code QR. Of course, I invite all the coaches to collaboration and discuss about the problem with the measure and the progress with the young development players. And I feel that connecting science with the practice is the future of the sport. If you have any question, of course, I will answer all them, I promise. But I want to explain, I'm late because we have a change plan.
Thank you.
Go to the next word. Thank you for inviting me. Thank you, Professor, because it's, in my opinion, if you help me to join to these people, to this colleague, to this team, it's improved me that our work It's important. It's important.
Thank you. Thank you,
very
Robert.
much.
Yes,
I'm
yes.
sorry, but I'm late and I must go.
Okay.
Thank you. Thank you, Robert.
Thank you very much.
Thank you, Michel. Thank you for your presentation, and then thank you for your participation. If our viewers have any questions, we can take them.
Send by
Just
mail.
a
Send
moment.
by mail.
Okay.
Thank you very much. See you on the next year, maybe.
I hope.
Of course, of course, of course.
Bye
See you
bye.
next year at our Congress. Thank you so much, Philip. Michel, sorry. Michel, thank you.
Michael.
Take care.
Easy, Michael. Michael.
Yeah, Michael. Sorry.
Michael. Like
sorry,
the Michael Jordan, you know, the
sorry.
famous player on the NBA. Michael Jordan.
Michael. Okay, okay. Okay.
Bye bye.
Sorry. Bye bye. And then Robert,
Yeah.
is Sebastian.
And
Sebastian.
maybe we wait the Sebastian. Yes.
Yes, I already heard the screen. Okay.
Yeah. Oh, let's try again.
Okay.
Yes.
Yeah,
Does
it's
it
okay.
work? Yes.
Yes,
Okay.
Sebastian.
Okay.
If
Thank
you
you.
are ready, you can start.
Yes. So sorry for the disruption. I had a small problem with the current website, but finally I'm happy I can present a small piece of my research I was doing currently and recently, actually, during my career. For today's presentation, I would like to share some of my ideas for mechanical properties of the muscle tendon units in rotator cuff tendinopathy. I'm from Poland, currently working at the Wrocław University of Health and Sports Science. I'm very happy to have this opportunity to present either myself and my presentation. Currently, I'm working as an associate professor at the university in Wrocław. I'm doing research. I'm working as a sport physical therapist, currently with para swimmers. Previously, I worked with track cyclists to the Olympic Games in Tokyo and Paris. I did some of postdocs in the United States, Denmark, and Spain. So my international collaborations are great, and therefore I can share some of my research findings to you. The main research interest I'm based on is rotator cuff tendinopathy. And what is that? So mostly it is a syndrome caused by some degeneration of tendons. Rotator cuff is located in the shoulder girdle. Actually, some of the muscles like supraspinatus, infraspinatus, subscapularis, and teres minor, teres major are building this small piece of tendon structure close to the greater tubulosity. Rotator cuff tendinopathy is causing mostly pain sensations due to some degenerative syndromes as ruptures, tears, overloadings. The main cause of those symptoms is also related to some intrinsic factors as inflammation, and therefore the main goal of my presentation and this small piece of my study is to investigate some mapping procedures called as spatial distribution mapping of the supraspinatus tendon, mostly related to elasticity in swimmers with rotator cuff and supraspinatus tendinopathy. The study design was based on a crossover study where 32 elite healthy swimmers was recruited for this examination, and we divided this group into two small crossover groups, where the first group was the study group with tendinopathy syndromes, and the control group, was healthy-based swimmers without any symptoms. During our study design process, we haven't excluded any of those swimmers. And each of this group participated in a high load, slow velocity resistance exercise procedure performed on the system Biodex 4.0. What measurements were taken into this procedure? So I just present the main preliminary, secondary measurements that were included into the big project, but finally I will just mention about the mechanical properties related to elasticity. Elasticity is a very important research finding, is a very important parameter because it may explain how the tissue react on exercise, on fatigue and overloadings. Previously, I mentioned about the supraspinatus tendon, so it is a very important structure, and I am using ultrasound examination and an additional tool that is called shear wave elastography to implement morphological properties related to thickness, so the whiteness of each sector of muscle tendon structure, and elasticity evaluated by and investigated, of course, by the shear wave elastography model. So first of all, just a quick snapshot into the ultrasound imaging of a tendon, because not everybody is familiar with those ultrasound measurements procedures. So just quickly want to share what are the layers we can see and where is actually the supraspinatus tendon implemented in our body. So as you see, the most superficial layer is of course the skin, is this fascia, is the superficial and deep fascia layer. Then the most black spot in the image above is the deltoid muscle. We need to remember that the deltoid muscle is covering the tendon itself. Then a very important structure, this bright white line is the bursa, is the subdeltoid subacromial bursa, and in between the bursa and the humerus with the humeral head is the articular cartilage and the supraspinatus tendon itself. So this bright head of a bird, because mostly it is called a head, is called a head of a bird. This bright space is the supraspinatus tendon, and mostly we take those pictures into different research and measurement procedures, and one of them is measuring of the thickness in 3 different research intervals. So it is 5 millimeters, 10 millimeters, and 15 millimeters above and distantly from the most hyperechogenic spot on the graded tubulosity. So this procedure is an original procedure to measure the thickness. And why I'm mentioning about this procedure, I took into space evaluation of what is happening in between those intervals focused on elastography. So in those intervals, I divided the tendon into 3 different intervals. So the most proximal, middle, and distal distance of the tendon. And then I used a sophisticated procedure in MATLAB coding for analyzing different areas of the tendon, focusing of two layers. So the bursa layer, the most tough segment close to the subacromial subdeltoid bursa, and the humeral head layers, so those spots close to the humerus. And my preliminary results in the group of swimmers with tendinopathy showed that the most accurate region of the tendon is the lower space, where the tendon is close to the cartilage and the humeral head, while the greatest stiffness we found above, close to the bursa, and it might be related probably to some changes in bursa thickness or the inflammation of the bursa. These results are the first results since 1994, where some researchers from Japan, they found some histological differences in layers between the bursa layer and the humeral head layer. And my study shows that changes in stiffness, so lowering of stiffness, might be mostly related to inflammation of the bursa and increased stiffness in the bursa layer. And it might due to some water content changes that it might looks like a sponge, that you can imagine the tendon looks after exercise like a sponge, and it is squeezed to the bottom of the humeral head layer. So the water content is going down, therefore greater stiffness is shown above, and lowering stiffness is investigated or observed below the middle point of the tendon. And the last very important observation, I can now try to explain or answering a question why the supraspinatus tendon specifically is tearing or ruptured in the midpoint of the tendon. So mostly it is related with some changes in avascularity. So this part, so the middle point between 5 and 10 millimeters distantly from the attachment to the greater tubulosity, this area is very less of vascularity, therefore it is very mostly related to some ruptures, overloadings, and tears. This is a snapshot of the results we obtained graphically to observe the spatial distribution mapping of the tendon. So as you see, the midpoint, so the middle interval of the tendon, is affected by greater stiffness, and the lower layer close to the humeral head is less affected, mostly caused by water content changes. Of course, the control group was not affected at all with changes in the stiffness and elasticity of the supraspinatus tendon. In conclusions, there are needed more measurements, and my current research is focused on a variety of different measurement outcomes, like some examinations of collagen structures, thickness as the main parameter for for the morphological properties, and we are going further with some vascularity measurements to investigate pain, because we need to remember that our patient is the important subject of our work, and we need to focus on pain and some extraordinary syndromes as overloading and injury. Thank you for your attention.
Thank you, dear Sebastian, for your presentation, and thank you for your participation. Just a moment. If our viewers have any questions, we can take them. We haven't questions right now. Dear Robert.
No, thank you very much. I haven't questions. Any question?
Thank you. Thank you so much. Dear Sebastian, nice to meet you. See you next year again at our Congress, I hope.
Yes, thank you very much for this invitation.
Thank you. Thank you so much. Have a nice day.
Yes, I think that is the finish now, the presentation in our laboratory and my colleagues. And I think that I hope that maybe we have the participation in the next conference and next Congress. And I wish you the best of all for us. And I think that my colleagues, 3 colleagues, Professor Wilk, Professor Kawczyński, and the Dr. Smuter, and sent me the presentation, your presentation, and I soon sent you.
Okay. Thank you, Robert. First of all, thank you so much, our Congress teams. We would like to see you again next year.
Yes, absolutely. Maybe we are planning the flight, the Turkish and Baku. Maybe.
No, thank you so much. Thank you so much. Have a nice day.
Have a nice day. Have a nice time. Thank you very much. It's my honor to be here.
Thank you. Take care. Take care, dear Roberts. See you.
See ya.
And then next work, Oana. Hello, Oana. Oana is here. Hello, Oana is here. Do you hear my voice? Yes. Oana, your presentation is here. Do you hear my voice, dear Oana? We don't hear your voice, dear Oana. We don't hear. Dear Oana, is there a microphone? We don't hear your voice. We see your presentation, Ona. But we don't hear your voice. Is there a microphone? We don't hear. Dear Ona, would you like to enter again? Would you like to enter again? Dear Ona. We don't hear your voice again. It's a problem. Okay, we are waiting. Dear Ona, your system. Dear Ona, do you hear? Okay, we are waiting. Dear Ona. Ona, do you hear? We don't hear your voice. No. Yes, dear Oana. Dear Oana. Dear Oana. Do you hear me, dear Oana? Dear Oana, dear Yes, dear Oana, your systems, I think there is a problem with your systems. So today finished our presentations. Our presentations will tomorrow, and then thank you so much all participants. Thank you for your attention. See you tomorrow. Thank you.